Hello, everyone, and welcome to today's webinar, Trauma Verification's November Q&A web conference. You have two audio options for joining the webinar. Phone call will be better audio quality. To use phone, select phone call from the audio pane of your control panel and the phone numbers will be displayed, or select mic and speakers and the audio will come out through your computer speakers. I would now like to introduce Molly Lozada, Trauma Verification Program Manager.
Thank you. Thank you, everyone, for joining today's webinar. And I'm going to go ahead and get started. So it's going to be myself and Rachel Sanchez, the site visit coordinator. And just a few things that I need to read. Continuing education. To qualify for CE, you must attend at least 15 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar ending with instructions on how to claim CE. If you have any questions during this presentation or about your CE, please email us at thecotrc@facs.org. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient, understand the processes and standards involved in an ACS trauma verification site visit, and how following these will positively impact the quality of care of the injured patient at your trauma center. With that said, we're going to go ahead and get started. So again, for those who are new to our webinar, please have a copy of the resources manual, or if you don't have a hard copy, you can download a PDF from our online website at no charge. Along with the resources manual, please be sure that you have a copy of the most recent clarification document and change log. Again, the clarification document is just purely that. It's going to clarify some standards that may be a little gray or a little nebulous. And then the change log will contain any changes we've made to the criteria along the way. The book is not reprinted, as I've heard from many people I speak with. So the book is not reprinted. It is the same book that was released in 2014. And again, any changes to those standards will be noted in the change log. Here are some useful resources for anyone who's new to this webinar or just new trauma program manager in their role. There's the recordings of the webinar. Again, we have those from 2016 to present date. The stakeholder public comment website is still available for anyone who wants to make any comments about the revision process. There are a few tutorials. And then there's the participant hub, which Rachel will cover a little bit more in her presentation. And then for those of you who did not attend last month in our webinar, we have expanded the FAQ and it has its own website. So there are about 130 to 200 FAQs that come up frequently, and they are listed on the webpage. All questions are pulled directly from the questions that are submitted. There have been no edits made to the contents. If your question is not answered today, the question may require more information, and we will receive a response from ACS staff within a week after the webinar. So with that said, I am going to turn the scheduling reminders and updates to Rachel Sanchez.
Good afternoon, everyone. Let's see, scheduling reminders will be presented every other month. We know that this can get a little redundant, so this will be every other month because we want to make sure that the new trauma program managers who are going through this process for the first time get their questions answered. So after November, the next presentation will be January 2019. As for the site visit application, it's online only, so you can actually access it on the following ACS Trauma website pages, the VRC Site Visit Application page or the Trauma Quality Program Participant Hub. After those links are clicked, it will take you right to the Account Center page. There you can log on, and once you log on, this is how your Account Center page will look. You'll notice that there's a contact section, and so we strongly urge everyone to update the contacts for the site visit. because these are going to be used for confirmation emails and also for final reports. And then you'll see underneath, you can request a site visit. And once you click on that, the application just drops down. So it's a quick one-pager, and you'll see that you can enter your preferred dates. And also, just to let you know, even though this is an online application, it must still be submitted at least 13 to 14 months in advance of the requested site visit dates, and must be before your expiration date as well. Also, you'll see on there, there's a place for alternate pathway review, which should be requested if you have a surgeon or physician who trained overseas and want to participate on the trauma call schedule. So their CVs also must be submitted to the COT-VRC inbox, as they will be vetted by a subcommittee for eligibility to go through the alternate pathway.
Can I interject a second here, Rachel?
Mm-hmm.
I just want to let everyone know, Rachel and I have been seeing an increase in alternate pathway applicants. So if you are going to prepare for a site visit, say in 2019 or even in 2020, please send their information. And you know you have someone on your panel that is not U.S. boarded and want them to go through the alternate pathway. You know, you can send that to us well in advance of your site visit, even before your application, just to make sure that they are approved. Because again, as Rachel mentioned, these folks, these surgeons are vetted by a subcommittee of their peers. It's not done by Rachel or I in the office. We just collect the information, and then that information is vetted by the subcommittee. So there may be a lot of back and forth going on because there's information that they want to gather based on their training. So they're looking at their training to be equivalent to that of the U.S. They're not looking at their fellowship. So again, they're looking at their training. So if you have a visit in 2019 and have not done this, this is the time to do it. Or if you have one in 2020, again, you know, early is perfect. So submit that going forward.
Thanks, Molly. So also on the application is you could also is the orthopedic trauma liaison form, which will need to be completed by all level 1 trauma centers. And also you can submit the form to the COT-VRC inbox with a copy of the OTL's curriculum vitae. And just so you know, we are accepting applications for June 2019 and onward. So your PRQ online access, once the application has been submitted, the VRC office will provide you with an email receipt of the confirmation. So this usually comes from the email is the COT inbox, and it's usually sent by Anita Johnson. And right in that receipt confirmation are your logins to the online PRQ. So you will get this pretty much, you know, right away after you submit your application. Also, the online PRQ can be accessed at that link right there, and a copy of the PRQ in Word can be downloaded from the following link. As for the site visit application payment, we ask that you do not send payment until you receive an invoice, and that you should receive within 60 to 90 days before your site visit. And then your center will be billed annually for the trauma quality program fee. There's a fee structure that's located at the following link. Scheduling the site visits. Visits are being scheduled quarterly. And so we ask that you provide us with exact dates that you would like to have your site visit. So for example, right now I'm working on scheduling the second quarter site visits. So if you know you're having a visit in the second quarter and I haven't received your the dates that you would like to have it on, if you wouldn't mind emailing me that, as well as those who know that they're going to have a visit in the third quarter, you can email me the exact dates you'd like your visit. The visit will occur on your chosen dates, but we may ask for different dates if the review team cannot attend the requested dates. Once the review team has been secured, you'll receive a confirmation email, and that will include your reviewers and all of their contact information. And this confirmation you should receive approximately 120 days prior to the scheduled visit. So right now I am working on March visits at this time. So if you have a visit in March and have not received your confirmation email, you'll be receiving that soon. I'm actually a tad bit behind on that with the TQIP conference and Thanksgiving holiday. And then site visit preparation with reviewers. The ACS travel agent will arrange the site reviewers' flights. Reviewers will typically make their plans approximately 20 to 30 days prior to the site visit. The hospital will arrange and pay for the site reviewers' hotel accommodations as well as their ground transportation. And we ask that you contact the reviewers directly within 30 days of the site visit for their flight itinerary and any logistical information that's needed. So we just definitely want to make sure that you are set up to have a successful site visit.
Thank you, Rachel. So we're going to go ahead and move on to announcements. So the announcement that I have is the next webinar. There's a short turnaround time, and we apologize for this. But as you know, with the TQIP conference and with the holidays, we're just going to have a short time for participants to submit questions. So it's the next webinar scheduled for Wednesday, December 12th. So if you want to just lock that in, and Sarah will send out an invite to all participants. So we're just going to go ahead and get started with general questions. So the question I had is a pediatric inpatient service required for a level 2 adult-only facility? The response is, if this trauma center is an adult-only facility, meaning no pediatric patients will be received and or admitted, a pediatric inpatient service is not required. And this would be true for level 1 or level 3, not just for level 2. Acute stress disorder screening tool. At my level 2 center, we are striving to improve on a cited weakness which stated there is no codified process for the evaluation of acute stress disorder in the trauma victim. Is there an identified screening tool that can be used in the acute care setting? The screening tools I have been finding have been lengthy, cumbersome, and often referenced in the past 2 months. In the past 2 weeks or in the past month. Also, is a recommendation intended for all trauma patients or just the ones that have complaints such as flashbacks or nightmares? So I know this has come up a few times during our webinars about PTSD or acute stress disorder. Just so everyone knows, presently screening for acute stress disorder is a recommendation in the Orange Book. It is not a requirement. So in some instances, if a trauma center, if during a site visit, reviewers see that there's the reviewing medical records or have discussions with the program manager or trauma medical director about acute stress disorder, and they're seeing an increase in patients with that, they may provide a recommendation or weakness in this case that to go ahead and start doing some screening. So in response to this question, presently screening for acute stress disorder is a recommendation. The trauma program may determine the criteria for when the trauma patient will be evaluated. As with the alcohol screening tool, the trauma program may create its own tool. The VRC webpage currently has one PTSD screening tool, and again, you can use that. The link is presented here at the bottom, and you can tweak that as you like and make that your own, but that is the one tool that we have. There may be others out there, but again, that is the one that we have. Our in-house CRNAs respond to activations and intubate most of the patients if needed. Are they required to have ATLS? CRNAs are not required to have taken ATLS. Burn patients, do burn transfer patients need to be transferred to an ABA verified center, or can they be admitted to any hospital burn centers? Burn patients should be transferred to a designated burn center that is capable of managing their injuries. It does not need to be an ABA verified burn center. Is all call coverage assumed to be 24/7? If I understand the question correctly, call coverage is required 24/7 for specific specialties. Some are required to be in-house and others are not. So if it's a level 2 trauma center and you have neurosurgery, they're required to be 24/7. Again, orthopedic, so there's some specialties that require to be in-house all the time, and then there's some that require to be on call 24/7 as well. Does the ACS assess a trauma center's evaluation of its injury prevention programs? For purposes of verification, we asked the trauma program through the online PRQ to identify and briefly summarize at least 2 injury prevention programs that address one of the major causes of injury. I inserted trauma because we're looking at trauma, injury in the community, and have the information available for review during the actual site visit. So the quick answer or the short answer to this is yes, we do evaluate the injury prevention program, and basically how that's done during a site visit is, and this is not true for all trauma centers, this is just some examples, it's done through a storyboard or in a 3-ring binder. Either is appropriate and acceptable. Neurosurgery criterion, level 3 with neurosurgery capability, where is the standard stating they must meet all level 2 ACS criterion? There is no criteria that states that a level 3 with neurosurgery capabilities must meet the level 2 criteria. So if you're a level 3 trauma center with neurosurgery capabilities, you are required as a level 3 to meet the standards identified in Chapter 8 and in Chapter 11 that is stated for level 3s. And these will include what is listed here, 8-5 through 11-68. Again, these are all for level 3 trauma centers that have neurosurgery capabilities. The last one, 6-3, alternate pathway, again, that may only be applicable if you have a non-US boarded neurosurgeon on the trauma call panel. So otherwise, you would not need to meet that standard. New TPMs, resources, other than the Orange Book, what are the most important things for new TPMs to review? I thought this was a good question because I covered this early on. And again, for new trauma program managers, I think slide number 7, in addition to the Orange Book, slide number 7 is extremely important. As I said, you got the clarification document, you got the change log, because the book does not get reprinted. So anything that changes in the book is going to be noted in that change log. And then slide number 8, there's the webinars for new trauma centers. There's 2 webinars actually, so those I think would be very, very helpful for new trauma program managers or even new trauma medical directors, as well as any of our webinars. And we've actually, I just can't remember if we said this before, but our webinars now have the PowerPoints of our slides attached to the recording. So if you don't want to listen to the recording in its entirety, you certainly can look at the PowerPoint presentation, download those, and look at the responses on those. Non-surgical admissions, non-surgical services admit is rates of greater than 10% the raw, all on non-surgical service admits or adjusted non-surgical admits with surgical consults. So the way the rate works is the rate of the 10% is based on the raw number of non-surgical admissions. So for best practices, you want to review all non-surgical admissions. If a patient is admitted to a medicine service but is transferred to a surgical service within 24 hours of admission, do these patients still count in our non-surgical admission numbers? If the initial admission was to the medicine service, yes, it would count towards your non-surgical numbers. Patient admitted to a non-surgical service reviewed by trauma medical director and deemed appropriate still negatively impact non-surgical service admission rate. Example, fall with multiple fracture, incidental findings noted with STEMI, admitted to medicine with ortho consult. A trauma center with a non-surgical admission rate greater than 10% is not seen as negative. I know it's written that way in the book, but it is not seen as negative by the verification program. In the scenario above, the admission and review is appropriate. Please keep in mind that if the trauma program admits more than 10% to a non-surgical service and are reviewed through the PIPs for appropriateness of care, it will not result in a deficiency. So again, having more than 10% non-surgical admissions to a non-surgical service, medicine, hospitalist, internist, etc., does not mean that the trauma center is going to be cited for a deficiency. The deficiency will occur if those non-surgical services are not reviewed through your PIPs process. So again, for best practices, you want to review all non-surgical admissions. What is the benchmark nursing turnover rate for ED and ICU? How high is too high? Although there is not a VRC benchmark on the turnover rate for nurses working in the emergency department or in the ICU, reviewers, and again, this is based on reports that we looked at, use an average of 20%, anything at the 20% number or higher to cite a weakness. Again, if your trauma center has a high turnover nursing rate, it does not mean that you're going to get cited a deficiency. What really ends up happening is the trauma center or the reviewers for that matter will cite the trauma center a weakness with a recommendation to look into why there's such a high turnover rate. Is there a projection for the next Orange Book edition or update other than the clarification document? Ideally, the clarification document is going to go away. That's the thought with the next resources edition. We don't know what color it is. I know I'm asked that tons of times, but the next resources manual will hopefully be released sometime late 2019 is what was reported out at TQIP or early 2020. Again, the data is fluid based on the progress of each of the chapters. They're being worked on simultaneously, so as soon as the chapter is approved or reviewed, then it needs to go through an approval process. It's a pretty lengthy process and it can take time if there's some back and forth going on. So again, the data is very fluid, but during the TQIP conference, it was reported hopefully late 2019 or early 2020. Have publication requirements for level 1 centers been revised? I believe this to be chapter 19 research. If I'm wrong, please reach out to me. At this time, no updates have been released about the research requirements. The chapter was revised. There were some proposed changes made, and it has not been approved as of date. So I don't want to release any information until that is approved because, as many of you know, things can happen or things can be changed by the executive committee. I know during the TQIP conference there were some comments about the chapter or the research being condensed with the 20 plus the 7. So they made kind of like they condensed the two. They combined the two and made it a little shorter. But again, I don't want to release anything in the event that something does change during the executive review. Orange Book revisions, what is the status of Chapter 16? When do you anticipate requiring the new taxonomy for PI, also associated with the PI chapter? Chapter 16 is currently under revision by the work group. All I can really say to this, because again, they're still working on this, has not been reviewed by the executive committee. The revision work group will incorporate and or edit standards based on best practices, evidence-based, and stakeholder feedback. So if there was information on the stakeholder feedback about the taxonomy or it's evidence-based or best practice, that will be incorporated into the new chapter. Staffing needs specific direction on ACS rules for appropriate trauma staffing. They include full program support, not just a number in, I believe that was registrars. I could be wrong what reg means, but it could be registrars. Aside from those requirements noted in the resources manual for medical and surgical specialists, trauma program manager, trauma medical director, registrars, injury prevention, etc., the additional staffing will be determined by the institution based on the program needs. So again, there are standards in the book. about who needs to be available or the personnel that needs to be present. And if there's additional personnel, again, that's going to be dependent on your program needs. Presently, again, the revision work group assigned to each of these chapters will identify and incorporate the staffing needs based on best practices, evidence-based, and stakeholder feedback. Again, there have been a lot of stakeholder feedback on having requiring a PI coordinator. Doesn't necessarily need to be a PI nurse coordinator, but we have discussed that at length, and it's a possibility that that may be one of the new standards coming forward. Is it a requirement to have the ability for EMS to call a trauma activation from the field in writing? This is not a requirement. I have not heard of this. There may be some other trauma centers who have had some experience with this, having EMS calling the trauma activation in writing. If you have, please submit your thoughts to the COT or your response to the COT via our inbox. There are some instances where the EMS will call an activation from the field based on predefined protocols. Again, that is dependent on the region and the county and the DOH, so that varies from state to state, but I've not seen anything in writing or heard of anything in writing before. What happens to a facility should they not pass a verification survey, probationary period, or stripped of trauma center status? I don't know if a probationary period for us is really almost like the focus period, and that is dependent on the following scenarios. So for re-verification or verification is granted for a 3-year period if there are no deficiencies cited. If the center was cited less than 3 type 2 deficiencies and no type 1 deficiencies, the center will receive a 1-year verification with the caveat that they have to have a focus review, meaning 12 months, which is probably in this aspect of probationary period, from the date of the initial visit. So they're verified through that year. So they receive a 1-year verification, they're verified through that year, and then if they have an on-site focus review or submit documentation and it's approved, it's appropriate to address the deficiency cited, then they would be extended an additional 2 years, making that the full 3 years. Now, if the center was cited more than 3 type 2 CDs or any type 1 CD, there is no verification, thus no probationary period, so the center would not be verified. However, they still have this focus period that they can either, again, have an on-site focus review or submit documentation based on the type of deficiency cited. And if they submit the documentation that is approved, then what happens in this scenario is their verification is extended from 3 years from their existing verification date, or if it's a new trauma center, from their site visit date. So there's a couple of ways to look at that. Again, it's all based on the type of deficiency, the number of deficiencies to grant them verification, and if they have exceed those numbers or the types, then they don't get a verification, but also they have the opportunity to address it and get verified. Do we need to provide actual copies of the board certification certificate? Would you accept copies of the verification obtained from the board certifying body's website, i.e. American Board of Surgery? So those are acceptable. We do ask that the board certification type and expiration dates are provided on the online PRQ, and copies of verification from the specialty boards are acceptable to have on-site during the on-site visit. Is it necessary to make an entire hard copy printout of your registry chart for your review charts? So there's 2 scenarios here. So if using paper or medical records, you will be required to print the entire chart for the on-site visit. If you're using electronic medical records, you will only print specific components of the chart for the on-site visit as follows. Again, and this all can be found in the review agenda on our website. So if you're using an EMR, you want to print the pre-hospital EMS run sheet, transfer facility ED info, if applicable, trauma flow sheet, H&P, consult notes, operative notes, report notes, discharge summary, autopsy report if available, and copies of PIPS documentation, other related information, again, if applicable to that medical record. And again, if you're still doing paper, you will be required to print all the medical records. Could you ever see where an entire state would move from state verification to all ACS verified centers? Absolutely. For example, the state of Georgia and New York were the most recent to move from state process to ACS verification. There are some exceptions based on state statutes in their designating process. So, for example, some states will review their own level 4s, and that's because ACS does not currently consult or verify level 4s. We have standards for level 4, but we don't consult or verify those. So there's some states that just, you know, if they have a lot of level 4s and they want them to be a trauma center, they will do their own state process. And then there are other states that may perform their level 3s, where ACS will do the level 1 and 2, and they will just own the level 3 process for their state. So there's a lot of variance out there on this process, but yes, I do see this being something over time for all states. How will the ED and hospital discharge info be reviewed during the verification? Is inpatient admission info under review during the verification? And if so, are there any specific criteria? Both questions have to do with the medical chart process. So the objective of the medical record review is to allow the review team to glean a logical flow of care, including assessment findings, interventions provided, capability of trending for vital signs, fluids, response to interventions, timing of care. That could be the trauma surgeon's arrival for, you know, tier 1, tier 2, limited, that's either the highest or limited, or the consult level, again, level of alert, pre-hospital care, etc. So again, there's no specific criteria other than ensuring appropriateness of care was provided. And again, during the on-site review, all these items will be reviewed during the medical review process, medical chart process, that is. So we're going to go ahead and move on to CD-related questions. Is the volume requirement for an adult level 1 trauma center, 1,200 trauma patients, or 240 admissions with an ISS greater than 15 based on trauma registry definition, which is NTDB based? Are there any additional caveats such as remove, ground level fall, surrounding, etc.? So correct, the volume criteria is based on either the NTDS inclusion criteria or that of your state if different than the NTDS. In some instances, your state inclusion criteria may include additional data fields than the NTDS, meaning that you may, as a registrar, they may have to capture 2 sets of data sets, one for NTDS and one for the state if you submit data to your state. There is one caveat that verification differs from NTDS inclusion criteria, such as the 23 hours observation patients who are discharged and not admitted to a service. The reason I bring this up because it does cause some confusion, and I understand that, and we are working to align our definitions in the new resources manual process. But for verification purposes, patients admitted to a service count towards the volume criteria. So all the tables that you see in the PRQ, if you're familiar with our PRQ, those data tables really are speak to those patients admitted to a service, and they have to match in some sort of form. And again, that is also on our webpage. If the ED is on diversion and another ED calls to transfer a patient for orthopedics but not trauma surgery, is that trauma diversion? That will not count towards the diversion rate. Diversion or bypass, we use the words interchangeable, is defined as the emergency department not accepting patients from the field, meaning by EMS. Where is the standard stating you cannot transfer a stable patient with a hip fracture to a non-trauma center due to insurance? If the patient is being transferred to a non-trauma center for specialized care or insurance purposes, that is appropriate as long as there are transfer agreements in place. these instances must be reviewed through the PIPS process. So there's no standard. You can't transfer these patients to a non-trauma center due to insurance or specialty care. We're just asking that if you are transferring them, that you review that care through the PIPS process. Are the requirements for trauma surgeons taking backup call the same as primary call, i.e. 50% at peer review? If the backup call schedule is comprised of trauma surgeons or general surgeons and they alternate with primary call, they are required to meet the same standards. So again, if they're your secondary team that may possibly alternate with primary call, they're required to meet the same standards as all other members, meaning 50% attendance, being current in their boards, and having an OPPE process, etc. Is there a surgeon response time required for level 2 trauma activations? This is the limited tier in this particular scenario. The institution will define the time and injury expectation for when the trauma surgeon, adult or pediatric, will respond for the limited tier. Most centers have a metric between 2 to 6 hours based on the mechanism of injury. The most important thing will be to monitor these metrics through your PIPS process. So again, there's a metric between 2 to 6 that's not set in stone. That's, what the general consensus is. There's some that I've seen as high as 8 hours or 10 hours. And again, it all depends on your institution and on the mechanism of injury that the trauma center sees over time. Therefore, when you look at CD 516, you want to monitor your limited tier activations for your under and over triage, because that may impact your rate. So you want to make sure you're monitoring your highest activation and your limited tier for that matter. Is there a time limit a program can be without a TPM dedicated to the trauma program before it's a deficiency? I feel like this is a trick question. So it would be concerning to me, first of all, that someone's asked that, is there a time limit? Ideally, there should be no time limit. There should be a TPM at all times for a trauma program. So it would be concerning not to have a trauma program manager for any, not have a trauma program manager for any period of time. Specifically, during the reporting period, they may impact the program's upcoming site visits. If during the on-site review, so say you're having your site visit Monday and you do not have a trauma program manager who is full-time and dedicated, that is when the trauma center will be cited a deficiency. Again, they're the captain of the ship, and you want to make sure you have a trauma program manager during your reporting year, or for any other period, you should always have one. General surgeons who do not routinely take primary trauma call but maintain current ATLS certification cover about 8 to 9 calls over a 60-day period due to an unanticipated leave of absence. Would they be required to attend 50% of the PI peer review meeting for that time frame, or would face-to-face review of their activations and missions with the teams suffice? So we see these as general surgeon locums, and if they're providing care to trauma patients, they're required to meet the same standards as the other trauma panel members, such as, again, current board certification, OPPE, and attend the trauma peer review meetings. Again, they can attend the peer review meetings, which I know it's challenging for a lot of surgeons or a lot of trauma centers. They can do it in person, or they can do it by phone conference or video conference. The second part to this, while it's ideal for these general surgeons locums to be current in ATLS, they're not required to maintain ATLS currency. So again, it's an ideal concept, but they're not required. Is it acceptable for the trauma surgeon to cover ED for in-house pediatric emergencies when only one ED provider is scheduled? So this is a level 2 trauma center. There must be an emergency physician in the emergency department at all times at a level 1 and 2 trauma center. That is a standard, and that is a new standard in the Orange Book, but it is a standard. Therefore, it is not acceptable to have the trauma surgeon cover the ED for times when the emergency physician is covering in-house emergencies. They'll have to get a backup ED or get somebody else to cover that in-house emergency. But so the ED should not be left uncovered without an ED physician. Pediatric surgical critical care. I know this is a little lengthy slide. We are a level 1 pediatric trauma center. I am looking into CDs 1017, 1013, 1148, and 1149. Can you please elaborate so I have a better understanding of these CDs? We currently have our PICU staff with the faculty who are all American Board of Pediatric Certified in Pediatric Critical Care, but not American Board of Surgery Certified. Our surgeons are not certified in critical care. When our patients are admitted, the attending is the pediatric surgeon, trauma. They work collaboratively with the critical care physicians to care for the patients while in the PICU. They co-manage the patients and final decisions done by the pediatric surgeon. Do we meet the standards for the for the above CDs? Based on what this reads here, it appears that the center is in compliance with the standard, with all 3 or all 4 standards, that is. And just to clarify, a level 1 pediatric trauma center is not required to have a surgical director who is boarded in surgical critical care. So that will meet the standard for 1033, 1148, and 49. However, you still need 2 physicians who are boarded in pediatric critical care medicine, which again appears that this trauma center meets the criteria for CD 10-17. CD 1151 addresses ICU coverage within 15 minutes, appropriately trained physicians. Can PGY 4 or 5 residents serve in this role? Yes. So this coverage may be performed by an appropriately supervised senior surgery resident, who can be PGY 4 or 5, or an in-house trauma attending credentialed to provide critical care. Please explain the role of the critical care surgical co-director. What evidence needs to be available during the review related to this? So in a level 2 and level 3 trauma centers, you can either have a director or you can have a co-director of the ICU who is actively involved and responsible for setting policies and administrative decisions related to patients, trauma patients in the ICU. So in some instances, this role may be served by the trauma medical director, in which their information, like their curriculum vitae, will be available during the on-site visit. So that is the evidence that's going to be presented during an on-site visit. So reviewers do look at that. The reviewers also look at the online PRQ, the information that is provided on there about their training, and also there's a couple of questions in the ICU section that ask what the coverage is for day, night, and backup. So they would gauge, they would have a sense of what takes place at your trauma center. So again, and the second piece of this is the majority of the evidence will be noted within the medical record. So as they're doing their medical record review, a lot of our standards, even though we may not have measurable documentation on site, will be visible to them during the medical record review and through conversation and during the pre-review dinner. So again, that's where a lot of the evidence and discussion will take place. Is a call schedule the preferred way to demonstrate hand call is available? A hand call schedule may be the best method, however, it is not required. What we tell trauma centers is to, if they're not going to have a call schedule, they're going to need to have they're going to need to be able to demonstrate who is providing hand coverage when the trauma attending requests the service. And what reviewers do not want to see is a piece of paper with a phone number on it or just a name. So it has to be some kind of, I hate to say the word formal, but it has to be some mechanism to demonstrate that there is coverage and you have someone's contact information on it. Do all mortality need to be reviewed at trauma peer review, or only those cases where an opportunity for improvement was found? So All trauma-related mortalities must be systematically reviewed, and those mortalities where opportunities for improvement should be identified for peer review. So if you have any that need to go for peer review, those should be the ones that you will present. And I just inserted this template in here, hopefully to aid some folks who want to see how this occurs. So again, the trauma program manager does a primary review, and if they find some opportunities for improvement, then they have a secondary review by the trauma medical director and trauma program manager. And if there's any adverse outcome, adverse events, or any issues with care, then, you know, that is where it will be presented to the peer review. So again, I think this is a really helpful tool. Nursing certification, please define advanced nursing certification education. We currently have nurses who are C-SPAN certified post-anesthesia nursing, ENLS, CNOR, CCRNN, CN. We understand that TCNN, TCAR, and ENPC are recognized. Correct. All of the above are recognized by the verification program as nursing certification education. While there are no specific education certification requirements for nurses caring for trauma patients, the trauma center must provide a mechanism to offer trauma-related education to nurses. Again, this is another area where the revision process will play a role in determining what types of certification and or education nurses will require for each of the areas, ICU, ED, trauma, etc. Alcohol screening, please clarify universal screening for alcohol use. Does the ED triage assessment of asking the patient if they drink how much qualify? If the ED triage assessment tool captures the information necessary to determine alcohol use, that will qualify. Again, previous slide, as I mentioned, the trauma center can create its own assessment tool for screening for the alcohol. Is the injury prevention program the totality of injury prevention events, or does a facility need specific programs in place? Ideally, the trauma program should capture the totality of injury prevention events. For verification purposes, and this is in the PRQ, we ask level 1 and 2 trauma centers to demonstrate at least 2 programs that address one of the major causes of trauma injury in the community. This may be equivalent to projects related to local issues. So if there's local issues going on in your area, or 2 projects concerning 1 issue, or 2 projects concerning 2 issues. However you want to capture this, we modify that is in the clarification document and also the change log. So for example, you can do alcohol use among adolescents, elderly fall preventions, stop the bleed counts as one of the injury preventions. Again, that was something approved by the VRC and the executive committee, and any other programs that you deem appropriate for prevention in your region or your area. Just had a couple of questions about CME. And again, these are just, clarification. I know there's been a change, and but still, there's still some clarification, and I'm happy to answer this. Level 1, adult. Level 2, pediatric. Please clarify the amount of pediatric-specific CME required for the TMD, TPM, and liaisons. So as you know, the CME requirement changed to 36 hours over the course of 3 years, which is divided by 12 CMEs annually, or you can do it all in 1 year, however you deem appropriate. And again, this is applicable to the adult and or pediatric trauma program, the trauma medical director and the trauma program manager, and anyone who has previously gone through the alternate pathway or will be going through the alternate pathway. They are the ones that are required to have CME. So how pediatric CME relates to this is that in level 1 and 2 pediatric trauma centers, we're asking the pediatric trauma medical director to have at least 9 hours of those 36 hours. We're just asking for 9 hours to be pediatric trauma specific. For the other members, trauma surgeons, pediatric surgeons, specialty panel members, just being enrolled or participating in their board's MOC/CC continuous certification meets the CME requirement. Does the MOC requirement have any stipulation for trauma-specific continuing education for surgeons or physicians? So my understanding is that MOC, or as I mentioned, CC, continuing certification, which some terms are changing, does not or is not categorizing CME as trauma-related or trauma-specific. Therefore, the verification program will honor those surgeons, physicians who are currently participating in their specialty board MOC/CC as meeting the trauma-specific CME requirement, or as meeting the CME requirement, actually. So what I wanted to say is, I know for pediatric surgery, they do not necessarily do trauma-related CME, as I was told by one of my pediatric reviewers. So again, MOC and CC, they're just, you know, if they're doing trauma CME, then that's fine, but we're not really looking whether or not they're doing trauma CME. We're just, right now, we're just asking trauma centers to be participating in their MOC board, their board's MOC. We are adult level 1 and pediatric level 2. Our CME required for adult providers and may come in contact with pediatric patients. There are no CME requirements for the adult providers caring for pediatric patients. Again, as long as they're participating in their specialty board, MOC, CC, it satisfies the CME requirement. Given the change to CME requirements, will centers going for pediatric status need to show pediatric-specific CMEs at any provider? So this is for a new pediatric trauma center undergoing review. Again, as I previously mentioned, in a 1 and 2 pediatric trauma center, just the pediatric trauma medical director must have 36 hours of CME, in which 9 hours must be pediatric specific, whereas the trauma program manager and anyone going through alternate pathway have to do 36 hours of CE and CME. And again, that could be peds and adult. It doesn't, or it can be all adult or all peds, however you want to do that. And again, for all other pediatric surgeons and pediatric specialty members, just participating in the MOC will meet the requirement. With the TMD exception, physicians only need take ATLS once to be counted in review as having had the course. What about nurses and courses such as TNCC? Must their card be current in order to be counted as having had the course? I wanted to also stress for this person that also as an exception in maintaining current ATLS are physicians who work in the emergency department who are not board certified eligible in emergency medicine, but who are boarded in another specialty such as family medicine practice or in medicine, internal medicine, etc. They have to be current. And then also the advanced nurse practitioners who are members of the activation team and participate in the evaluation and resuscitation efforts, they also have to be current. So again, I just wanted to clarify that. There are no requirements for nurses to maintain current status in their TNCC or any other certification, so we're not mandating that at this time to demonstrate that. So I want to thank everyone for participating in today's webinar, and we'll see you next month.
Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification's November Q&A web conference. If you have any other questions, please contact COTVRC@facs.org. On behalf of Trauma Verification and our presenters, thank you for joining us today and have a great rest of your week.